everybody. I think we're going to go ahead and get started. Welcome back to the Grand Rounds here for sports medicine. Just to, there's a couple sign-in sheets going around, so please sign in if you haven't already or track one of those down. They should be probably somewhere up near the top at this point. So we'll have a couple great talks coming here today. The first of our talks is going to be given by Dr. Matthew Grierson. Matthew has an interest in dance, and he's going to be talking a little bit about risk factors for dance-related injury with practical applications for our sports med providers. So welcome, Matthew.
Good morning. Thank you, Dr. Rao, for that introduction and for inviting me out to speak. And thank you, everybody, for coming out this morning. I know it's early. For those of you I haven't yet met, I'm one of the Physical Medicine and Rehabilitation Sports Med Fellows here at the University of Washington. And my undergraduate degree was in modern dance, and as such, I have a special interest in dance medicine and dance-related injury. And so the topic of my discussion is risk factors for dance-related injury, with a special emphasis on practical implications for the sports med provider. Here's a brief outline of what I'll be discussing today. First, I'll introduce you to the concept of dance medicine, and then we'll discuss barriers and challenges that dancers experience when navigating the system. I'll then move on to a more general discussion about dance-related injury, focusing on common concepts and issues that a more general sports medicine provider should know. And then at the end, if we have time, we'll go over a couple of clinical cases. All right, so let's get started. Does anyone recognize these two pioneers of modern dance? Anybody? I'll give you a hint. The theme of my presentation is Pacific Northwest and Seattle-based dancers. Any takers? It sounds like several of us have a bit of homework to do in terms of Googling dance history pioneers. But the dancer on the right is actually Merce Cunningham. And if you don't know him, he was actually born in Centralia, Washington, and is one of the more famous modern dance choreographers of the last century. And he's pictured here just after leaving Cornish College, where he trained. And then he went off to join Martha Graham in her dance company. Her name may sound more familiar. She's the one on the left, and this picture was taken in the 1940s. But the reason why I show these pictures is these are two pioneers of modern dance who really embody the notion that dancers are both artists and athletes. They spend their career pushing the boundaries of human motion to create and perform complex artistic routines and choreography. Ask any dancer who's taken a Graham or Cunningham class, and they'll tell you how much it really kicked their butts. But in dance, there's an inherent tension between this desire to push boundaries and the more practical fact that a dancer must accept the inherent limitations of what their bodies can achieve. Choices a dancer makes in the moment will undoubtedly affect whether or not, for instance, they get picked in an audition, but really how important is it for you to be picked in an audition if you're too injured to dance the part? And as a dancer, you're always making choices in the moment. How important is it for you to be dancing 1 hour from now, 1 day from now, next week, next month, 1 year from now, 10 years from now? And again, that's why I picked these pictures, because here again are our two modern dance pioneers dancing well past the ripe old age of 50. And some of you in the room may take don't think that's such a ripe age. And I would agree with you. In fact, the two of these dancers danced and choreographed well into their 80s and 90s, which is pretty impressive. And trying to understand the factors that influence dancer health and longevity is really what gets to the heart of and foundation of what interests me in dance medicine. And so when I use the term dance medicine, I think a lot of people don't exactly know what that means. Usually people who haven't been exposed to the term think of what's going on in this photo here. And again, keeping up with my Seattle-based theme, this is a photo from Mark Morris's dance studio. And although actually his studio is in Brooklyn, he's a Seattle native, and he's actually going to be here in a couple of weeks with his company. But this is actually a photo of a dance therapy class for Parkinson's patients who have Parkinson's disease. And there's been certainly a lot of research in terms of the use of dance therapy in treating Parkinson's disease and functional outcomes. Very important work, certainly, but not my area of expertise. And there are lots of things I think people think of, from dance therapists to kinesiologists to physical therapists. And all these people are very important team members of the dance medicine team, but not my role as a dance medicine provider. As a physician, my role is really more one akin to the sports medicine physician, helping to diagnose, treat, and prevent dance-related injury. But before we get to the topic of dance-related injury, I wanted to talk a little bit more about the culture of dance and the culture of medicine, because there are a number of barriers that I see that prevent me from fulfilling my role as a physician and caring for dancers. I'm not sure if any of you saw the recent New York Times article about a little over a week ago, talking about the difficulties artists in general have in terms of getting access to healthcare. And while obtaining healthcare insurance for artists who don't often make a lot of money from their craft is certainly a very interesting topic, I think the issue of dancer health and wellness goes much deeper than the simple question of whether or not a dancer has health insurance. And so here I have a diagram of the dancer-doctor relationship. And as in any relationship, there are going to be competing interests. This graphic just depicts some of those interests and the barriers that prevent the free flow of information between dancer and doctor and vice versa. On the left, you have the dancer is influenced by her family, her colleagues, her instructors, choreographers, directors, and employers, all sharing circles of influence. Then on the right, you have the physician whose interests lie in using available knowledge and research to diagnose and treat patients and prevent injury. And the barriers of free flow between the two include both real logistical issues, like whether or not a dancer has health insurance or whether or not they're even employed, and also barriers in perception. This can be anything from the local dance subculture in a particular community to a dancer's perception of pain and pain tolerance. These can all influence the relationship. And actually, this has been an issue that I think is really important, but actually has not been really well studied in the past. And so me and several of my colleagues last year embarked on a study to really dissect the doctor-dancer relationship and see if we could better understand why dancers are making the choices that they do regarding the health and what they value when looking for a healthcare provider in the healthcare setting. So we surveyed 36 dancers, university college dancers, somewhere at UW and somewhere at Cornish, over the course of a semester, asking them about their preferences regarding their healthcare. And then we followed them over the course of a semester to see what patterns emerged. Overall, there were 55 injuries and 25 dancers. Most of the dancers were female. And they were college students, meaning that they were required by their university to actually have health insurance, and the vast majority of them had a really good relationship with their primary care doctor. So it took out that compounding factor of having access to health care. And at the beginning of the semester, we asked them, what were the most influential factors that you use in selecting a physician? There was little surprise here that most of them were looking for physicians with a good reputation who participated in their insurance network, and many were hoping to find someone with some personal experience in dance. And probably not too surprising is the fact that the vast majority of them indicated a strong preference for non-surgical over surgical providers. 87.5% versus 5% indicated that was their initial preference. When asked what they were looking for most when they visited with a physician, most were hoping to have an accurate diagnosis. The vast majority of them, over 50%, said that was their number one priority. And coming in second was the development of a feasible treatment plan. Although, as an aside, I think what constitutes a feasible treatment plan for dancers probably may or may not be congruent with what seems like a feasible treatment plan for their providers. Other important factors and characteristics that they thought were important was whether or not a physician was personable, whether or not they offered non-surgical treatment options, and whether or not they spoke dance terminology. But interestingly enough, of those 55 injuries, only 18% of those dancers actually sought treatment for those 55 injuries from a physician. And so we were wondering, what is the issue? Why are not many dancers actually going to see a physician for their health care? And maybe the problem was that the injuries may not have been as severe that they felt the need to see a physician. So we studied it further. And so we asked the dancers what their confidence was in a physician's ability to diagnose or treat dance-related injury. And the red bars here show and we did pretty well as far as their confidence in our ability to diagnose a problem. The vast majority of them found them completely to moderately confident confidence in a physician's ability to diagnose a problem. And although we didn't fare quite so well with developing a feasible treatment plan, at least the vast majority were at least neutral, if not moderately to completely confident in our ability to give them a good plan. But if only 18% of the dancers, despite being fairly confident in our abilities, if only 18% of them actually saw a physician, where were they actually getting care? And so then we asked them what their preferences were in terms of if you did have a dance-related injury, where would you seek treatment from? And as you see in this graphic, their first choice, which is listed in blue, is their dance teachers. And so the vast majority of them, almost 50% of them, would go to their dance teacher first to discuss an injury, followed by a physical therapist. And I think a lot of this had to do with access to their teachers and physical therapists, certainly. But interestingly enough, physicians came in, there was a close race between third and fourth place between physicians and dancers' colleagues, or other dance students. And then if you look at the red bar graph, pretty equal distribution between their second choice providers. I think what this graph really demonstrates is that we need to be cognizant of other members of the healthcare team and their influence on dancer health. Everybody certainly has their role to play. And I want to be clear that this study was not designed to create value judgment upon which of these providers should rank higher or lower within the dance medicine team. Although I probably would be lying if I didn't at least mention that my ego was a little bit bruised by the fact that after all these years of training, I'm held in approximately the same regard as dancers' other classmates. But it is what it is. I also think it also brings up the interesting point about generalizability of these results. The culture here in Seattle is fairly permissive in terms of a dancer being able to go to their teacher to report an injury and discuss ways to modify choreography. And so they're very comfortable in using them as a resource. And I think this data may be much different if I would have surveyed like a professional dance company or a company in New York or California. So certainly this was an interesting pilot study, but there's a lot more work, I think, to be done in this area. So now that we've discussed a little bit about the culture of dance medicine, and I've introduced you to the dance medicine team, let's now focus our attention to the dancers themselves and their propensity for injury. So here's my disclaimer. Not all dancers are created equal. I use the example of ballerinas here, and again, I'm trying to keep in my Pacific Northwest theme to my slides. So here in the top left corner, we have one of the principal ballerinas from Pacific Northwest Ballet dancing a very classical dance, grand jeté, across the stage. In contrast, I have two other very different styles of ballet. At the bottom left, the dancer is from Montreal, and she's known from a company very well known for their ballistic movements and maneuvers across the stage. And if you look at her body type, at least, almost what you would expect from a professional wrestler, you can begin to understand how, even though she is dressed as a ballerina, and it's certainly influenced by the same movement vocabulary, she's going to have much different stresses and strains on her body than the woman above. And finally, I have the picture on the right, which is a photograph from Matthew Bourne's adaptation of Swan Lake. And if anyone has seen Swan Lake before, it's traditionally choreographed on all female dancers. And this is a male dance troupe. And actually, they were dancing in pointe, something that male dancers don't typically take that role. And so all these dancers are using similar movement vocabularies, but introducing different types of stresses on their body. And it's all called ballet. And so the same inherent variability is seen across all dance forms, from ballet and tap to modern and jazz, and yes, that even includes social dance forms. As an example, my grandma just called me up a couple weeks ago, like the night before Valentine's Day, asking me for permission to dance at a Valentine's Day dance with her 86-year-old husband. She wanted to dance the waltz like 2 days after receiving an epidural steroid injection for painful radiculopathy. So we had a very interesting discussion about functional goals and value. But there is a lot of variability in what a dancer means, the definition of what a dancer is. And I told her no jitterbug. But and I apologize because I'll get off my soapbox soon, but you really can't take a one-size-fits-all approach to treating dancers and preventing dance-related injury. We have companies out here like the Dance Company, where we have mixed ability dancers creating edgy work, challenging our notions of beauty and ability and the extremes of motion. And I always have the primary goal of when they get injured, these types of dancers, to help them return to their craft as quickly as possible, maximizing function. But when they come into my clinic, I not only have to account for their knees and their ankles, which they may or may not have, as you see in the photo, but I've got to account for their prosthetic limbs, their wheelchair, et cetera. Again, always with the primary goal of helping them return back to their craft as soon as possible, maximizing function, but also engaging in discussions of how to prevent another injury from occurring in the future. And so dancers are difficult to categorize, and there are many dance genres and dance forms. And yes, it's important to understand the movement vocabulary as a provider of sports medicine, but maybe that's just as simple as asking them to describe the movement for you. Or if you have a free Friday night, you can go watch their performance. Or now we're living in the age of iPhones and iPads, and so I've even had patients, when I see them in clinic, actually show me a brief stint of their choreography so I can see exactly what may have led to a particular injury. And, but as we move into a discussion about the epidemiology and risk factors for dance-related injury, I think we also need to keep in mind, because of all of this variability, it's hard to generalize all the research that's been done on dance medicine to the greater dance community at large, because most of the work has actually been done on professional dance companies, specifically professional ballerinas. And then, of course, definitions of injury certainly vary across the literature, although more recently, the dance medicine community has come to embrace the time loss definition of injury. So, although the data is not ideal, what is clear is that dancing is dangerous. I think dancers typically see pain as an accompanying facet of dance practice, and dancers are often prone to dance through pain, even when doing so may be detrimental. So take a look at these statistics here, and these are from professional dance companies, showing pretty high incident rates of injury for both ballet and modern in USA and in Europe, rates of 75 to 85% per year. And that's actually on par with American football injuries, and that's a statistic from the 1980s. I don't imagine it's changed much since then. But for a professional ballet dancer, that equates to about 6 or 7 injuries per year in a professional dance company. Now, not all of those are certainly obviously career-ending injuries. Many of them are, again, just using that time loss definition of at least 1 day. But it is important to note that dancers are getting injured quite frequently and are able to work through a lot of these injuries. And if dancers are getting injured so much, what types of injuries are we seeing in them? Most of them, the vast majority of them, involve chronic overuse injuries of the back or the lower extremity. And this is just data from one dance company. There's a lot of data throughout the literature looking at this. This is one company in New York looking at 53 dancers, and they had 355 injuries over the course of a year. Most of them were muscle sprains, ligament sprains, muscle strains, and tendonitis or bursitis. And of course, if you have a dancer who participates in a modern dance company, they're going to, or doing much more lifting, they're going to have a different profile of injuries than someone who's not going in and out of the ground, someone who's not using their arms, or participating in like floor-based movement patterns that require weight bearing of the upper extremities. So let's go through some of the risk factors for dance injury, and then I'll introduce you to some common clinical scenarios that you'll probably see at some point in clinic, and we'll investigate answers to the questions supported by the research. And so here's a list of some of the risk factors for dance-related injury, and you'll see that there are both intrinsic and extrinsic factors, and many of these are modifiable. It can range from anything from a dancer's level of training, are they adequately warming up, do they know how to listen to their body and the signs of fatigue, to their technique, are they really forcing their turnout, and is that putting them at a disadvantage down their kinetic chain, or do they have problems with like muscle imbalances and core strength? Or is it an issue with the environment? Is there not enough lighting in their environment? Are there structural hazards? What's the room temperature like? Is their floor sprung? And what that means is most dancer floors, well, a lot of dancer floors are sprung, and what that means is it just has more compliance for when a dancer lands to absorb forces. Or it could be a problem with the choreography. There's certainly some pieces that I've seen in the past where the whole dance is danced on the right side of the body. And certainly that is an artistic choice that is possible, but if that whole company is having injuries just on the right side of the body, you might challenge the choreographer to see how necessary that choice was for them to make. Or is there too much jumping in the piece and things like that? So there are many risk factors for injury, and I think it would be most helpful at this point to maybe take a look at some of the more controversial issues and the types of things that you might see when a dancer comes into clinic. So now here's some time. I know it's early for a little bit of audience participation. Thumbs up for true, thumbs down for false. So I've got a couple of these clinical scenarios that we'll go through. So instituting a formal dance medicine program, including an on-site physical therapist, is a cost-effective means for reducing a professional dancer's risk for dance-related injury. Thumbs up for true. Yeah, it seems like all of us are getting the message on that one. So this is actually supported really well by the literature. There are two studies that were performed on dance companies. One was in New York on Alvin Ailey Dance Company, and the other was done on the Boston Ballet. And they followed these dance companies for 5 or 6 years after adding an on-site physical therapist. And what they saw was their injury rates plummeted, and the workers' compensation claims really went down in addition to a decline in days lost from dance. And so with the Alvin Ailey Dance Company, their overall injury rate went from 0.52 down to 0.25 injuries per 1,000 hours dance. And for that rate, that's over a 50% decrease. It saw, in terms of total injury incidents, 34% decrease in that, and then 66% decrease in workers' comp claims, and 56% decrease in days lost from dance. So pretty significant figures. What I also thought was interesting in the Boston Ballet piece was that over the period of time that they were doing this study, they actually saved $1.2 million in workers' compensation insurance premiums after adding an on-site physical therapist because their dancers just weren't getting as injured quite as frequently. And I think what these two studies highlight is the fact that with attentive healthcare for dancers, both preventative and restorative, this is associated with reduction in injury rates. And it really does pay to have in-house medical and physical therapy services to reduce the financial impact of dance-related injury. And the benefits of this certainly are probably they're not having to go back and forth between a physical therapy studio, there's reduced time away from class, better communication with the director and choreographer, and earlier attention to complaints. So pretty clear answer there. Yes, true. It's important to have good access to physical therapy services for dancers, especially in the professional companies. Here's the next question, or scenario. Dancers achieve an adequate level of aerobic training when participating in a dance class, rehearsal, performance to maintain optimal cardiovascular fitness. So are dancers good at maintaining cardiovascular fitness? Kind of mixed answers in the audience. I see probably about half of you got the answer right. But false. And this is a little bit counterintuitive because we think of dancers as pretty active athletes, and we see them on stage as a pretty active, what they're doing, dancing across the stage. But this was a study from 2012 where they used accelerometers to account for, and it was 137 dancers in a pre-professional dance classes affiliated with a dance company. And what they found was dancers were really only moderate to vigorously active for about 10 minutes per hour of dance class. And interestingly enough, that level of activity was the lowest in the highest level dance classes. And part of this was probably related to the fact that the more proficient ballet dancers in this company were not having to work quite as hard to learn the routines and things like that, and so they were able to focus a little bit more on their craft and their technique. Interestingly enough, and I guess this isn't too surprising, is about ballet classes offer a lot less time for physical activity compared to like tap or jazz, where you're doing more movement that gets your heart rate up, and whereas with a ballet class, the first half of your class is spent at the bar in a very structured warm-up setting. And so I think the moral of the story here is to always ask dancers what they're doing to prepare and what type of cross-training activities that they're participating in. And it has implications certainly for their physical and mental well-being, but also for performance, because in this study, which was done in 2004, they were looking at heart rate, and they also looked at oxygen uptake parameters and found that these parameters were rarely at a level consistent needed for aerobic performance or improvement. And the dancers actually really needed that improvement for their dance performances, where they relied more on higher heart rates and oxygen uptakes than what they used in dance classes or rehearsals. So this isn't something that you're just telling them to do for their health. This is something that's actually going to improve their craft. And a recent study, a meta-analysis performed in 2009, actually showed that from all the studies that they looked at in the meta-analysis, there really was no significant difference between all the structural and functional cardiac indices between full-time contemporary dance students and age gender-matched controls. So I think that's very interesting. So let's look at our next scenario. Professional female dancers, and this is again along the same lines of cross-training. Professional female dancers should be careful when participating in strength training programs. Increased muscle strength has been shown to negatively impact the dancer aesthetic. Thumbs up or thumbs down? It seems like everyone here is not too worried about people's thighs becoming really thick with muscles. And you're all correct. It actually doesn't impact the dancer aesthetic. There's not a lot of studies in this area, but the ones that do have pretty striking results. So this was, I mean, the N was small, N of 22, but it was a randomized group. Half the dancers in a dance company were given a structured strength training conditioning program for the lower extremities, and the other half just participated in their regular training. And of course, the people who performed strength training got stronger quadriceps muscles, torque in their lower extremities, and better endurance, especially for those dancers who had been weaker. But what they saw was that increases in thigh strength weren't actually correlated with an increase in thigh circumference. And so that's more of a structural way to answer the question. Another one is to look at aesthetics, and this is certainly a more subjective measure. I don't know if anyone's been following the Olympics, but there's a lot of subjectivity in things like ice dancing and things like that. But this was a study from 2001 looking at 17 dancers, and they randomized them between two intervention groups. One got an aerobic and strength training program for 6 months, and the other just did their regular routine. And their performance was evaluated through a 4-minute dance sequence before and after the intervention. And they found that those people who did perform work in the strength training and aerobic training program did much better, if the P was 0.03, than the gains that were seen in the control group. So not only is it not necessarily going to affect the structure of their bodies, it's actually going to improve the aesthetic of their dancing if they participate in these cross-training activities. So definitely I tell all my dancers when I have them come see me in clinic, it's very important for you to be participating in strength and cardiovascular training outside of the clinic, outside of the dance class setting, and it's going to help them for both their general health but also their performance as well. All right, here's my next topic. Are there strict age-based cutoffs for when a young ballerina should attempt point work? True or false? Are they strict? It seems like everyone's saying yes, there are strict age-based cutoffs. Well, let's investigate this a little bit further. So what is point? It's when dancers they use very specialized shoes to dance on the tips of their toes. And the position here shown is the position of releve, and that's when people go up on their toes. And the one on the left is a dancer in point, and the one on the right is just a dancer just going up on releve without point. But I think the primary concern here is the negative impact on the growth plates of the feet of a young dancer, especially the first digit where most of the weight is borne at the tip of this toe. And there's some reason to have concern. We see in other athletic populations, specifically gymnasts, who do a lot of activity with upper body, putting weight on their upper body, especially with repetitive forceful motion. They can develop injuries to their radius growth plate, leading to positive ulnar variance. But interestingly enough, in dancers, this isn't something that's commonly seen, despite the fact that dancers go up on point typically at an age in this country around 11 or 12 years old after 3 or 4 years of dance training. And interestingly enough, actually that growth plate doesn't actually fuse all the way until later in adolescence. And so if the issue isn't exactly a strict age-based cutoff because of growth plate issues, then why are we making the decision for when a dancer should be going up on point? Because, and you may see this actually in clinic, there have been people who have, when we go to these international meetings on dance medicine, some people get mothers and fathers who bring their kids in asking for x-rays to make sure that everything's all right for their kid to go up on point, and this really is not necessary. The more important factors is, are they going to be safe when they go up on point? And so you're looking at the range of motion of their ankles, their knees, their hips. You're looking for their strength, and you're looking for their ability to stabilize and control their motion as they go up onto their toes. And then it also relates to what are their goals moving forward, because point training is a very rigorous training program, and certainly someone who's only dancing 1 day a week, a couple of days a month, it probably doesn't make sense for them to go up on point. But a really good, well-validated test that people use when assessing dancers' readiness to go up on point is what's called the airplane test. And this is really an assessment substantially related to like core stability and neuromuscular control along the kinetic chain. And so what the dancer does is takes their arms out to the side, extends 1 foot, and then pikes forward on the standing leg. And once they get to horizontal, they plie and bring both their hands to the ground and then come back up. And as you can see, I'm not ready for point training. But what you're looking for when the dancer does this, and you have them repeat it 4 or 5 times, you're seeing whether or not they can control their pelvis, whether or not their knee is going into varus or valgus alignment, and if they're able to control the stability of their ankle and maintain a good position throughout the whole procedure, or the whole maneuver. And so if they can do it 4 out of 5 trials, I think that's a good indication that they're ready for moving on to point. Just keep in mind that there are a lot of each dance school often will have their own standards that they also adhere to, such as a dancer must have to be within the studying in the dance program for like 3 or 4 years before moving on to that level. And so the question may not be, is it too early to start point because of bone issues? They may not have the technique, and you may delay having a dancer go up on point until age 14 or 15 for that reason. Or you may talk to them about exploring other dance forms. So the next topic. There's evidence to suggest that an impairment in core strength is an independent risk factor for dance-related injury. True or false? Seems like everybody's got their thumbs up. And actually, this is another topic that's near and dear to my heart. Several of me and my colleagues, I graduated from residency here at the University of Washington in rehab, and there were actually 3 of us who were very interested in dance medicine. So we embarked on a project not only to look at the dance healthcare issues, but we also looked at core strength in dancers and what its relationship was with injury over the course of a semester. And again, we had our 36 dancers, and we did baseline measures of core strength and followed the dancers over the course of the semester to look at injury patterns. So what did we actually look at? We looked at hip strength using a dynamometer to measure force output of hip abduction and hip external rotation. And then we looked at the typical core endurance measures that you often see in the literature, the McGill measures. And what those are, you have the dancers hold certain positions, and you see how long they can hold that position before falling out. And those positions are measuring for the anterior abdominal endurance with holding it like a sit-up position, and then you look at right and left lateral bridges, looking for kind of lateral core strength, and then a Superman pose to look at the posterior musculature. And then we developed a couple of dynamic dance-specific assessments that I won't necessarily go into because it involves a lot of French and explanation of what those types of moves are. But here's what our dancers looked like. Most of them were their early 20s. Many of them had over 13 years of dance training, and most of them had been injured at some point in their life. 86.1 of them had previously been injured at some point. But let's go through this graphic showing the results of hip strength and how that was mitigated the risk for injuries. And so the brown bar graphs in this graphic are the right side, and the black or gray are the left side. And if you see a plus, that means that dancer was injured over the course of the semester, and a minus means that dancer was not injured. And so looking at hip abduction on the right side, you go up to the top and you see the p-value is 0.7. So there really was no difference between their performance on hip abduction strength and whether or not they were injured over the course of the semester. And we see the same trends on both the right and left side for hip abduction and external rotation. And this was an interesting, certainly there were ways we could have improved this study, and we'll look at some of the other measures that we looked at, but really none of them panned out in terms of showing that there was any association between any of the measures that we looked at and whether or not a dancer got injured over the course of a semester. Here is the data from the core endurance testing. And again, these were the poses that we had the dancers hold for a certain number of seconds, and we measured until they fell out of the pose. And we actually used a laser to make sure that we were very precise. So when they fell out of the laser, we could tell when they had fallen out of the pose. And interestingly enough, the brown bar graphs in this picture are the injured dancers. So they actually did a little bit better on these maneuvers than the dancers who were not injured. But again, none of these were actually statistically significant. I think the Superman pose approached statistical significance at 0.53, but like when using a Bonferroni correction, none of them really even came close. Our data was just our study was just a preliminary study. Certainly, I think it's something that needs to be investigated further. All we had was 36 dancers, and what we found is when you ask dancers to do something, they're going to try and do it to their best, and they find ways to cheat the system, and they do the same thing in their choreography. They try to find ways to make it work. And so I think a lot of our measures, they were finding ways to keep their body within that pinpoint of the laser pointer, but they sacrificed in terms of like the technique of the actual. They weren't actually using their core strength. So we'll see what the future pans out, but we didn't actually find a correlation between these baseline screening measures and self-reported dance-related injury over the course of a single semester. But despite this, of course, core strength is a very important component of dance training. If it doesn't pan out that it relates to injuries, certainly for the dancer's craft, it is very important. And what this also points out is this is one of the first studies to actually look at this, so there's ample opportunity for future study. And so let's get on to a couple of cases that I've prepared for you. Now, these cases are from a local group that I am involved in. And me and my colleagues, along with Dr. Nancy Cato, we set up a free dance clinic for injured dancers here in the Seattle area. It's for dancers who don't have health insurance. It's called Seattle Dance Medicine. And these are cases from our clinic. All the photos used are not actual photos of any real dancers, so there are no HIPAA concerns. But interestingly enough, if any of you know any dancers who do have injury and have lack of access to care, we do hold monthly free clinics, and so you can refer them to our clinic. I'll show you the web address at the end of the presentation. But here's our first case. It's a 14-year-old dancer who's been dancing on pointe for about 2 years. She's developed pain behind her knees, worsening over the last 2 months, worse with jumping, dancing, walking. There really was no specific injury to account for her symptoms. She has no instability symptoms, no mechanical problems, locking, clicking, anything like that. And in the assessment, her mother pipes in, "Oh, and my daughter's one of the top dancers at our local dance studio." And so just based off that information, I started to develop a differential diagnosis. Does she have an osteochondral lesion? Is this a stress fracture? Does she have a ligament problem, a meniscal tear? Or is this a posterior lateral corner injury? Or is this more related to hypermobility and joint pain related to that? And so as the mom was actually telling me how special her daughter was, she pulled out a photo that looked very similar to this. And it was pretty striking in terms of what had been going on. If you look at the dancer in the middle, you can see her knees are very hyperextended compared to her other classmates to her right and her left. And then I went on with the rest of her exam, and fairly benign findings, although she did have weak hip abductors and weak hip external rotators, and as all dancers do, I think that's a very common finding. I asked her to do, I did a postural assessment. I did a couple of functional dance maneuvers. I had her stand in first. And for those of you who aren't aware of all of the dance positions in ballet, I've got them shown for you. I think for someone starting out, I think it's probably just most important to know the first two. So first position is where your heels are together and your feet are turned out. And second position are where your heels are apart. And so if you can remember first and second position, you're miles ahead of most other people. But just be aware that there are 5 positions. And so I had her stand in first, and again, that's the one with her heels together. And here's a picture of what she looked like when she was in first position. And as you can see, her knees are together, but her heels are apart. And also looking at her pelvis, she has increased lumbar lordosis, anterior pelvic tilt. And actually, when I examined her, I also did a BOINTE exam looking for hypermobility because it's very common in dancers. And she had a grossly positive score at 7, meaning that she could bring both of her thumbs to her wrist and both elbows hyperextended and both knees hyperextended, and she could touch the ground with the palms flat on the ground. So she was hypermobile. And that's a very common finding that we see in dancers. And so based on all of this and the fact that the rest of her exam was fairly benign, we diagnosed her with having, with her hyperextending her knees too much, and this being more of a biomechanical issue that could be corrected with technique modifications. And so what did we do for her? We actually recommended a taping technique. This was more for proprioceptive information than anything else. We did this cross-X technique that we did across her popliteal fossa, and it really just provided proprioceptive feedback so that she didn't have that propensity to hyperextend at the knee. And we asked her to wear that throughout her daily life because actually, even her daily walking, even as she was just standing, leaning against the wall, her knees were really hyperextending. And so she had developed this pattern, not just in dance class, but throughout her daily life, and this was something that we really had to challenge her to fix. And then we had her talk to her mom talk to her ballet teacher to make sure that she wasn't also having the same problems in dance class, and that they were focusing a little bit more on her technique and her pelvis positioning and making sure that she wasn't hyperextending her knees so much. Instantly on follow-up, and again, our dance clinics, we only hold them once a month, so we actually saw her, I think, 3 or 4 months later for a different issue, and her knee pain had completely resolved. And this is what she looked like when we asked her to stand in first position. Of course, she still had that ability to hyperextend her knees. She had just developed the neuromuscular control and the movement patterns to avoid doing it so frequently. And I think this case really brings up one of the important issues of dance culture and how this interacts with when a dancer comes to you in clinic. When I was researching hypermobility issues, I come across this posting from an online blog for dancers, and I'll just read it to you, and it kind of shows some of the cultural issues that we're working against. My ballet teacher told me that having hyperextended knees is really beautiful for a ballerina. I'm pretty sure it's not a bad thing because my ballet teacher loves my legs because of it. Many great professional ballerinas have really big hyperextended knees. Here's a picture of one right here. There's really nothing you can do about it. Just embrace it because there are so many dancers who only wish to have those legs. And so I think the question is, certainly a lot of what we see in ballet is an artificial aesthetic, and so much of work in treating dancers is helping them come to terms with the structure of their own bodies and helping them understand the difference between using a dance aesthetic to their benefit on the stage versus allowing it to be a crutch to cause pain and to prevent them from participating in their craft. Certainly all dancers have something that makes them unique, and that's what draws you to them on stage. And so maybe not all dancers have hyperextended knees, and that's okay. And so at this time, just because of time, I'm going to skip my second case. But I will leave my contact information up. I'm happy to send anybody a copy of my slides. My email is matthew@dansendoc.com. There's no G, dansendoc. And instantly, that's also my email address, or my website for Seattle Dance Medicine is www.dansendoc.com. And that's where dancers can get hooked in to hear about our free clinic. And we also hold a monthly journal club to discuss common topics in dance medicine here in the Seattle community. And anybody's able to attend those: physical therapists, athletic trainers, MDs, dance teachers, anybody with an interest. And so here's some other resources of places you can go to if you're interested more about dance medicine. So I think I've got about 45 seconds for questions. Thank you so much for listening.
Change of pace. So anyways, I surveyed you guys mainly because there's been interest from an administrative end on possibly getting actual CME for these lectures. I haven't actually formalized any CME for this series over the course of its 10 to 15 years, however long it's been going. So I just was curious what the interest was in the group, and feel free to email me. This is 47 of you guys who responded. The bottom line is that most people seemed, when they're asked how important is getting CME credit for sports medicine GrandRounds, the majority of people were sort of lesser interest. So like I say, 34% reported that of being 34% of you said of little interest, and not many people said this was essential. About 20% said very important or essential. So, and then just ask if you were offered the opportunity to pay $40 to $50 for CME, which is actually what it would cost to kind of defray the cost to the departments of doing this. The majority of you said no. So. For now, I'll wait for any more directed feedback, but I have a lot of other things to do, and if there's not that much interest in it, then I'm not going to really push the agenda right now. So feel free to disagree with me. There's a lot of different suggestions, and so we'll take all of these into account. I've noted all of them, and so we'll try to incorporate these into future lectures. So let's talk a little bit about some Super Bowl photos. So, I just, for all of you guys as part of this community, this was a really cool opportunity, and just wanted to take a moment to share some of these photos with you. It sort of felt like a very unique experience for Dr. Dresner, Dr. Herring, and I, at least at the UW, and Dr. McAdam and Calfane at Swedish to be part of something like the Super Bowl. Very unique experience. There's myself and John, who's I think here. This is just some of the craziness that happens at these events. That's Richard Sherman in the center, responding to about 500 media. I took all these photos, by the way, so they're not copied from Google or anything. Just some interesting moments. I was able to you really get to be part of this experience, and I've sort of would love to share a lot of these more officially, but I figured I'd give you this opportunity to take a few. There's Golden Tate with his Google Glass and GoPro, recording the whole event. Russell, being Russell. It's me and Marshawn. This is our medical group. We have one of the best medical groups, athletic trainers, chiropractors, orthopedic surgeons, physiatrists, and primary care providers, in my opinion, in the NFL. And this is the majority of that group out in Times Square area. It's MetLife Stadium night before the game. Jerseys getting readied. This is some of our medical team. Bottom left is Dr. Herring, then the whole medical team there. This is the day before the Super Bowl, and then obviously John, friend, mentor, all of the above for me. It was great to share that experience with you. And Super Bowl trophy. It's Jermaine Curse for all of you guys who cover UW sports. Jermaine was a big part of UW for many years, and I handed him off my camera and said, hey, you mind taking a picture of me? So that's him taking a picture of me. So Macklemore showed up afterwards, and then Dresner and I having a good time. It's a parade which all of you guys have heard about afterwards, and that's it. Go Hawks! So hope you guys enjoyed that little prelude. So our next lecture, Brett's going to get set up here in a second. Is going to be given by Dr. Brett Toresdahl. Brett is our current primary care sports medicine fellow. He has a lot of interests. He's an extraordinarily talented researcher, and we're looking forward to see where his career heads off after this. For this particular lecture, Brett's going to be talking about skiing and snowboarding injuries, which is relevant to this time of year, especially with the type of snow that we've gotten this year, and talking a little bit about prevalence and prevention to that end. So that will be his lecture here in a moment, I think. Hopefully we'll, yep. So welcome, Brett.
All right, great. I think we're good. All right, so I'm Brett Toresdahl. I'm the current family medicine, sports medicine fellow. I'm from Bozeman, Montana originally, and so this is a topic that has been kind of a part of my life since probably age 3 when I started skiing. And it was part of the reason why I went into medicine, and specifically sports medicine, is having suffered a number of skiing and snowboarding related injuries, and also having observed a number of friends involved and have lives changed by skiing and snowboarding injuries, whether having devastating head injuries or being caught in avalanches. So this is something that for me is really enjoyable to read about, learn about, and share with you. So this is going to be our template for today, our outline. So we're going to first start by looking at some demographic information, then go through some of the common musculoskeletal injuries, then talk about head injuries, and then some of the environmental considerations for skiing and snowboarding. All right, so let's jump into the demographic information. Skiing and snowboarding, as many of you know, is a very popular sport in the US. There's about 57 million skier and snowboarder visits per year. That results in about 8.2 million skiers and 7.4 million snowboarders. The majority are male, more male than female snowboarders compared to skiers. And just in this audience, how many skiers do we have? Okay, great. And how many snowboarders? All right, so it looks like it makes up just about everyone here. All right, so compared to other sports, there are about over twice as many skiers and snowboarders nationwide compared to high school athletes. This is a very large industry, $3.4 billion estimated, of which a significant amount is targeted at injury prevention. In terms of who's participating in the sports, this is ages versus skiing and snowboarding. So you would expect the younger ages we tend to see more snowboarders, and then at some point around age 35, people start skiing, and I guess I have a few more years before I have to start skiing. So we'll be looking forward to that transition back. Looking at the competitive side, there are a few different venues for elite competition. The yearly and the annual events are the FIS World Cup. Then there are the X Games, and then every 4 years, as many of you probably watched, is the Olympics. In skiing, there are both the alpine events and freestyle events. There's X Games, it's just freestyle events. And while ski cross was developed and kind of marketed by the X Games, they recently dropped that event, so it's now seen only in World Cup and Olympics. As far as snowboarding, there's less events, which makes sense as it's a younger sport. There's a couple alpine events, that's the parallel giant slalom and parallel slalom, and then the majority are the freestyle events. Again, X Games was part of snowboard cross becoming popular and has recently dropped that as well. This is the first year for slope style for both skiing and snowboarding in the Olympics. All right, so let's take a look at some of the musculoskeletal injuries. I want to review some of the common ones, but we're certainly not going to be able to go through all of them. So I'm picking out a few of the common ones, but also others that are just unique for skiing and snowboarding. So in terms of injury pattern, skiing, there's a 2-to-1 lower versus upper extremity ratio of injuries. In the past, when there were leather boots and cable bindings, there was a preponderance of ankle and tibia fractures. Now with more supportive boots and bindings that release, the trend is towards more knee injuries. In snowboarding, it's the opposite. It's 2-to-1 ratio of upper versus lower extremity injuries. This is in part due to the fact that the bindings do not release, and snowboards are shorter than skis, and so you have a shorter lever arm acting on the lower extremities. There's a higher risk of fractures in snowboarders, 2.5 times greater risk, and then the majority or half of the injuries occur in beginner riders. What's different compared to skiing is that half of those beginner riders have no formal training or formal instruction, which may contribute to their injuries. So let's take a look at our first specific injury. Some of you might recognize this. This is last year, February of 2012. This is Lindsey Vonn. And as a result of this injury, she was unable to participate in the Olympics this year. So we're talking about ACL injuries. That's when she tore her ACL that time. In recreational skiers, females are at higher risk of ACL injuries, but in World Cup skiers, there's an equal risk in males and females. So in the graph over here, the big circle, that's all ski injuries. Knee injuries make up a large portion of all ski injuries. And ACL injuries in particular make up 60% of all knee injuries and 20% of all ski injuries. In snowboarders, it's much less. Only about 2% of all injuries in snowboarders are involved with ACL. And in most major U.S. ski resorts, the ski patrols see between 1 and 4 ACL injuries per day. There's a few different mechanisms described in the literature about how an ACL injury occurs. The most common is what's called the phantom foot, or a backwards twisting fall. This is when somebody loses control and starts to fall backwards. Their hips fall below the level of the knees, and they try to recover from the fall by putting more force in their downhill ski. What happens is the ski will go out in front of them. The phantom foot effect is the tail of the ski holding them up, and then there's also an internal rotation component of this, which results in the ACL injury. The other is a valgus external rotation, or a forward twisting fall. This has to do with, can be a result of bindings being improperly adjusted. And then lastly is a boot-induced anterior drawer, seen in jumping when somebody lands on the tails of their skis and the snow catches the tail of the ski, and the force results in the boot actually acting on the knee like an anterior drawer that we do on exam. In snowboarding, there's a few different ways that this is done. First is in the terrain park with different freestyle jumps. The other is with novice riders getting on and off the chairlift. This is due to the fact that their rear boot is taken out of the bindings when they're getting on and off the lift. And if they're inexperienced and a little unstable, riding with only one foot buckled in, they're more at risk to falling, and this can involve a large lever arm when the entire snowboard twists around a single leg. As you see in this picture, this guy is at greater risk because he is in the terrain park and has only one foot buckled in. In terms of prevention, there's a few different things that people have discussed in terms of primary prevention of ACL injuries. The first is ensuring proper adjustment of the bindings, making sure the bindings release when they're supposed to, making sure you're staying in control, especially when the ski conditions are variable, which was the key word when I was growing up and listening to the snow report on the phone, that anytime it said variable conditions, it meant stay far, far away from the ski hill. The other one is be familiar with the landing of jumps, so you're not landing on the tails of the skis. Don't fight in the fall. Some will advocate for learning to fall forward rather than backward to avoid that phantom foot effect. And then with snowboarding, with the novice riders, encouraging them to get their rear boot buckled in as soon as they get off the lift, and not trying to ski down part way with only one boot buckled in. There's been neuromuscular training programs that have been advocated for ACL prevention in other sports, and so while not studied in skiing and snowboarding, this is something that certainly has value and may need to be investigated in the future. As for preventing a recurrent ACL injury, a research group from the Steadman's Hawken Clinic looked at functional bracing in people who have undergone an ACL reconstruction. They showed that in their group that had no bracing, there was a 9% annual incidence of a recurrent ACL injury, though in the functional bracing group there was only 4%. And so they strongly advocate for using a brace similar to this in those who have undergone reconstruction and want to continue skiing. There are a few other ways. Just Googling ACL prevention, some company thinks that if you have skis that have a very short tail, this removes the phantom foot effect, and so you're not falling backwards and being held up by the tail of the skis. I don't see these on the ski hills, so I'm guessing it's not popular option. Moving on to the next musculoskeletal injury. This is the ulnar collateral ligament sprain of the first metacarpal phalangeal joint, also known as skier's thumb. This makes up about 8% of all ski injuries. This occurs when somebody falls onto their like an outstretched hand while holding onto the ski pole. In terms of prevention, people have looked at trying to develop poles with straps that break away so that they're not landing on the grip of the pole. This was not shown to be effective. Others advocate that you should simply let go of the poles when you're falling so that you don't have the pole acting on that joint. Here's one simple way that people have shown that you can avoid landing with the pole in your hand is by using the strap of the pole backwards. So instead of looping it through as you might expect, you hang your wrist, the strap around your wrist, and then grab the pole, so that if you are in the event of a fall, as we see in this third picture here, you're more likely to have the pole out of the way when you land. There are a few other companies that want to develop new poles that protect the thumb, or new gloves that have more support to prevent these injuries, but again, not much research on that. All right, moving on now, wrist injuries. This is one of the more common injuries for snowboarders. The most common, 2/3 of these are a fracture. Distal radius fracture is the most common, and among beginner riders, it's typically extra-articular, and then with higher speeds, higher force with our more experienced riders, it's usually intra-articular and comminuted. The mechanism, as you would expect, falling onto an outstretched hand. This either happens when somebody lands from a jump wrong and crashes, or catches an edge. This is a couple guys on the snowboard cross who look like they are both falling onto both outstretched hands. The prevention of this is pretty straightforward. Wrist guards are very effective at preventing wrist injuries. Studies have shown that it decreases the prevalence of, or the incidence of wrist injuries by 50 to 75%. But for whatever reason, they're worn by less than 10% of riders. Some research has shown that it's typically based on comfort, and that wearing these wrist guards is kind of a hindrance. There's others that have been other gloves. This one you can't really see, but it does have a wrist guard built into it, and those seem to be more tolerable. One other way that we can look at in terms of preventing wrist injuries is try to prevent the catching an edge and falling on an outstretched hand. In some of, not in the medical literature, but just in information provided for ski and snowboard tuning, most snowboards are from the factory have edges that are very sharp all the way around, and in fact, you only need to have the middle toe and heel side edge sharp to be able to maintain an edge when you're turning. So the contact points, as you see in this diagram, are usually where a snowboarder will catch their edge, especially when they're just learning to snowboard. And so you can detune those edges by taking a file and making those edges dull. And the further towards the middle you go, the less likely you are to catch an edge. And so this may be one simple way to avoid those falls and those wrist injuries. So another common injury in snowboarders, while not common, it's unique to snowboarders, I should say, is the fracture of the lateral process of the talus. This is also known as the snowboarder's ankle. It makes up 2% of all snowboarder injuries, but when you're seeing a patient in clinic who's injured their ankle snowboarding, you have a 1 in 7 chance that this involves a fracture of the lateral process of the talus. Prior to snowboarding, this was more of a case report type of injury, and now it's being seen more commonly. There's a 15 greater risk of this fracture in snowboarders compared to the general population. There's a few different mechanisms that have been described for this injury. Most of them involve dorsiflexion, eversion, and external rotation. Some have said that this can be done with a dorsiflexion and inversion, or simply a fall from a height. The diagnosis of this one can be challenging because it presents exactly like a lateral ankle sprain. There's what's described as a LPT test, which involves essentially reproducing the mechanism of injury, which is dorsiflexion, eversion, external rotation. And if there's pain felt at the lateral ankle at the site of the lateral process of the talus, this is positive. Conventional x-rays don't always show a fracture of the lateral process of the talus. While it's not standard, some have said that you should get the foot into plantar flexion and internal rotation to try to better visualize that lateral process. If you have a suspicion, CT scan is best. There was a case report of somebody seeing a doctor 15 times prior to the diagnosis of a lateral process of the talus fracture. So it's important to have a low threshold in snowboarders who come in with ankle injuries to get a CT scan if they're not improving as expected. There's 3 types of fractures of the lateral process of the talus. Type 1, which is a small bone chip. Type 2, which is a large fragment. And type 3, which is the comminuted type. And depending on how displaced they are, it determines if it's a surgical or non-surgical treatment plan. There's no studies yet on prevention of this injury in snowboarders. There's a couple of ways that we could consider advising patients on how to prevent this. One is which you can simply minimize the amount of external rotation at baseline to prevent this injury. So if you think about our snowboard here, these bindings would be considered in a neutral stance where they're exactly perpendicular with the axis of the board. Most freestyle riders do have a bit of external rotation of both bindings, usually 15 to 20 degrees in the forward boot and 5 to 15 in the rear boot. And so the difference of these angles, the greater the difference, the greater the external rotation, and you could conceptualize that this may increase their risk of ankle injuries, not only the fracture of the lateral process of the talus, but just lateral ankle injuries in general. You could even draw a Cobb angle here to help measure that if you're interested.
Does that tend to happen more in the leading or the rear foot?
It hasn't, none of the research that I reviewed described that, but it would be a good question. All right, so let's talk about head injuries now. And maybe another video to open this up. This is Shaun White in the X Games in 2010. This is a quote from an interview after. He says, "I don't know, I'm a snowboarder and I didn't want to give up. I cracked my head pretty good. I was pretty dazed after that one." Later that day, he went on to win the gold medal in the half pipe. As in other sports, head injuries and concussions have started to become a focus in skiing as well. There was a recent article in Outside Magazine about the risk of head injuries, and it reviewed a few of the more prominent cases and some of the factors that go into the observation that there's been an increase in head injuries in skiing and snowboarding, especially in the freestyle disciplines. And I'll just describe through some of the discussion of that article right here. So it describes kind of the anatomy of the half pipe. So we have a few different places where somebody could conceivably get injured. On the half pipe, there's the deck, the lip, and then the flat, where they're in the transition. So in the 1980s, when half pipe and snowboarding was first being developed, the depth of the half pipe was between 4 and 8 feet. And over time, we've seen that increase in size quite dramatically. It went to 12 feet in the 90s, 15 feet mid-90s, 18 feet in 2002, and then what we're seeing today is a 22-foot pipe. And during this time, there's been no really apparent concern for injuries as the size of the pipe has increased. We also see people like Peter Olenek, who has the world record for the most air in a half pipe, going 25 feet above the lip. So this, we're talking about somebody being about 50 feet above the flat, which is often icy and hard. So just doing a little bit of physics, that would be disregarding all rotational forces and speed. You would be looking at a 40-mile-an-hour fall or impact when they hit the flat. There's a few really key injuries that have been highlighted over the past few years in skiing and snowboarding half pipe. The first is in Kevin Pierce. He was expected to be a medalist in the 2010 Olympics in Vancouver, and was thought to have the best chance of beating Shaun White. The year prior, so in 2009, he was training in Park City, Utah, and took a head injury. He was doing kind of a forward rotation flip, landed face first in the flat, and suffered a devastating head injury. He has been able to return to snowboarding, but not competitively, but his recovery has been very prolonged. And just this couple weeks ago, a documentary was released on his recovery, his injury, called The Crash Reel, and I encourage you all to take a look at it. It's just in terms of you don't necessarily have to have an interest in skiing and snowboarding, but it goes through how a family deals with a traumatic brain injury and how it affects somebody whose life has revolved around sports. The other one is Sarah Burke. 3 years later, in the very same half pipe that Kevin Pierce had his injury, she was training and suffered a similar head injury. She died 9 days later. She's a skier from Canada, and so she was really a big part of getting skiing half pipe in the Olympics. And so for the Sochi Games, they spread her ashes and did a number of tributes for her during these games. In terms of prevalence of head injuries, it makes up about 10 to 20% of skiing and snowboarding injuries. There's about a 3 times greater risk in snowboarders compared to skiers. When there was a study at Taos about before and after snowboarding was allowed, that there was an increase, a 2.2 times increase in head injuries reported by the Ski Patrol. It's the leading cause of disability and death from skiing and snowboarding, and in about half of them are due to colliding with a stationary object. The prevention begins with helmet use. This has been something that prior to 15 years ago or so was not very commonly seen. Studies on this showed about a 15 to 60% reduction in head injuries, but none of the studies to date have evaluated specifically concussion, and most would suspect that along with other sports, helmets do not prevent concussion in skiing and snowboarding. There were initial concerns that it would increase risk of C-spine injuries and also increase risk-taking behavior, but the studies on this showed that this is not, in fact, the case. So let's take a look at helmet use over time. So one end of the graph, we have 2002, 2003, when only a quarter of skiers and snowboarders were using helmets. And we jump ahead to this past season, we're now at 70% use. And so this is a dramatic increase. And think about, there's been some health promotion campaigns to encourage people to wear helmets, but very few laws or requirements to wear helmets. So this is quite a bit of improvement in terms of helmet use that we've seen. As for who are wearing helmets, we see that the 18 to 24-year-old age group is the demographic that tends to not wear helmets, and then it increases again after that. Let's talk a little bit about helmet quality. This is a helmet that was seen after the slopestyle event in the Olympics this year from one of the Czech Republic riders. The helmet's being held by one of the other competitors. That's why you see a British flag there. That would be considered a one-time use helmet. Safety standards, there are 2 main safety standards. There's an American and then a European safety standard. The ASTM is the American one, and then the European one is the CE 1078. Both of these are voluntary for manufacturers to meet in the US. There's no laws on that like there are with bike helmets. And then the American safety standard, it's only tested at 14 miles an hour. And that's something to really consider when we're talking about downhill skiers going up to 80 miles an hour. And then we have freestyle skiers falling from heights of 40 feet. There's two different kinds of helmets nowadays. It used to be all single impact foam, the EPS foam, as pictured here. In the last few years, we're starting to see some multiple impact helmets. There's different types of foam that are used for those, and these are a few of the brands of helmets that are used. Those are a little more expensive, but definitely worthwhile talking to your patients about if you're seeing them for concussion evaluation or just kind of overall trying to prevent injuries. If you're talking to a snowboarder, just encouraging them to, a skier or a snowboarder, to talk to them about making sure they're safe on the hill. I mentioned a little bit about helmet requirements. In North America, there was a law that was proposed in California. It passed the legislature but got vetoed by Schwarzenegger. In New Jersey, they did pass a law requiring helmets for those ages less than 18. The way they kind of legislate this is that if somebody is caught without a helmet who's aged less than 18, they actually fine their parents about $100 for the first time. In Nova Scotia, it's required in all ages. In Europe, they have a little lower age requirement, less than 14 in Austria and Italy, and less than 13 in Norway and Slovenia. It's required in all competition, World Cup, Olympics, and X Games. In terms of concussion policy in the U.S. Ski and Snowboard Association, the one that's published online describes a mandate for participants to be removed from training or competition if they're suspected to have a concussion and be evaluated. However, it only applies to those athletes that are less than age 18. It does not prohibit them from returning the same day, and there's no baseline testing required described in that concussion policy. So this is far different from what we see in some of our other sports that we cover in high school athletes, NCAA sports. All right, so let's take a look at some environmental injuries that are unique to skiing and snowboarding. And let's start out with another video. Right, so let's hope that this guy made it out okay. Avalanches result in the death of about 12 skiers and snowboarders annually in the U.S. Most of these occur in skiers, and most occur in the backcountry. This is a graph that describes the fatalities caused by avalanches in the U.S. of all kinds, not just skiing and snowboarding. But if we look just at the amount that are skiing and snowboarding related, we do see that is increasing along with others, such as snowmobiling. There's a few ways to prevent injuries and death from avalanches. First is just being very educated about the risks of avalanche. There's a lot of resources that are available for skiers and snowboarders who wish to venture out into the backcountry. First is being familiar with the avalanche forecasts that are available online. Ability to assess snow layers. This is a picture of a person digging a snow pit and determining if there are any unstable layers and how deep they are. Recognizing the risk of the slope based on the grade. So 38 degrees is the highest risk for a slide, and you can take a little tool with you, which is pictured here, that can help you measure the grade of the slope. And then traveling in groups is important, especially in the backcountry. Though, as we saw a couple years ago, traveling in groups is not a fail-safe method of preventing death from avalanches. You may have heard that there was a group of 16 professional and other ski industry folks who went skiing in the backcountry near Stevens Pass. 5 of them got caught in an avalanche. 2 of them escaped. One was able to wedge himself into a tree. Another deployed a airbag connected to her equipment and was saved, but 3 did end up dying. The whole event was documented in great detail through a New York Times article called "The Snowfall," and it's still available online. It's definitely worthwhile reading, and this article won the Pulitzer Prize for feature article. As far as formal education for avalanches, this is something to certainly encourage your patients to if they mention that they are interested in backcountry skiing or involved in this. The American Institute for Avalanche Research and Education, or ARI, has a standardized avalanche training course that's offered by a number of organizations locally. When somebody ventures out into the backcountry, the basic equipment that they need includes an avalanche transceiver, a shovel, and collapsible probe poles here, which can be used to help find somebody in the snow if they are buried. There's some new technology that's come out over the past 10 years. One is the RECO rescue system. This is a little device that's sewn into clothing, helmets, boots, and is used within ski area boundaries for the majority of the time to help locate somebody who's been buried. It uses harmonic radar technology. The other is an avalung. This is something that it's a sling that can be worn under clothing or be kind of incorporated into a backpack. It allows somebody to breathe fresh air, and it pulls in air through the snowpack and exhales the carbon dioxide kind of at the opposite side of your body. It allows you to survive buried for a longer period of time. And then last is the inflatable airbag. This is similar to what was used by the skier near Stevens Pass and can help keep you above the snow in the event of a slide. Similar to avalanches, a couple weeks ago, there was a skier at Crystal Mountain who died after falling into a tree well. This would be something described as a snow immersion suffocation or a non-avalanche related immersion death, often caused by falling headfirst into a tree well and being buried. It results in about 4 deaths per year in North America, often within ski area boundaries. The prevention of this is simply staying in control and skiing real close with a partner, especially when the snow is deep. Some have advocated just keeping a whistle in your pocket to help your friends find you if you're not carrying an avalanche transceiver, if you're in bounds. It's a low-tech way to let somebody find you. All right, next topic for environmental injury is altitude. I have not skied this glacier. This is at 15,890 feet in China, but you could imagine there might be some problems with ascending to that altitude. So there are a number of medical issues that occur when lowlanders ascend to altitude. What we're going to just focus on is acute mountain sickness, which is what you would commonly see among your skiing and snowboarding population who go to altitude. Acute mountain sickness occurs in about 25% of people when they're over 6,500 feet, going from sea level. And that includes 76 North America ski resorts have a base area above 6,500 feet. And so it's certainly something that you may experience. You may have patients ask you about when they're, say, traveling to Denver or somewhere else where they're staying at a base area that's at altitude. High altitude cerebral edema is on the extreme spectrum of acute mountain sickness and occurs less frequently and only at higher altitudes. There's only 7 North American ski resorts that are above 9,800 feet for their base area, at which you would start to be concerned about high altitude cerebral edema. The risk factors, there's an individual susceptibility to acute mountain sickness, and more is being learned about that. The final elevation reach, and specifically the elevation that somebody sleeps at, is a risk factor, and the rate of ascent. This is a picture of Breckenridge, where the top of the chairlift is at 12,800 feet. Here's just a description of some of the symptoms that people experience along the spectrum, from at the mild end high altitude headache, and at the other end high altitude cerebral edema. Headache's a major component of all of this, and then in the middle you start to develop some of the nausea, vomiting, dizziness, fatigue that's seen in acute mountain sickness. The prevention of this is to transition to altitude slowly, so making sure that you are not going to elevations above, say, 9,000 feet in one day, limiting alcohol, sedative medications, and then limiting activities in that first day or two at altitude can prevent acute mountain sickness. You also want to risk stratify your patients in terms of their risk of acute mountain sickness. This is something from Auerbach's text on wilderness medicine that was adapted from research by Andy Lux here and others. So it describes a moderate risk of acute mountain sickness as somebody who has a history of it, ascending to 25 to 2,800 feet in a day. If they're ascending greater than 2,800 meters in a day with no history of acute mountain sickness, and if they're ascending quickly, or if they have plans to ascend quickly above 500 meters a day, over 3,000 meters, when they do have a day of acclimatization. And then higher risk, certainly if you've had a risk of acute mountain sickness and you're ascending to greater than 2,800, if you've had a history of high altitude pulmonary or cerebral edema, and then if you're ascending to a high altitude in one day, or if you're planning on ascending quickly without a day of acclimatization, you're at high risk. So if you determine that one of your patients is at moderate or high risk, you can recommend acetazolamide prophylaxis or Diamox. This is a 75% effective at preventing acute mountain sickness. In adults, it's half the treatment dose, which is 125 milligrams twice daily, and they start this one day before they leave and continue for 2 to 3 days. Also can be used as dexamethasone if somebody's allergic to acetazolamide, or can be used in combination if needed. So cardiology, finally, this was not something that was on the original outline, but I feel like with some of the folks here, I can't give a presentation without involving some aspect of sports cardiology. So we'll get some audience participation with this last slide. So see if anybody can recognize this skier snowboarding athlete. I'll give you some hints. Tetralogy of flow. 2-time Olympic gold medalist. Flying tomato. And so that would be Shaun White, who's one of the few elite athletes who has recovered from a congenital heart disease. All right, so thank you so much. I'll take some questions if you have any. Yeah.
Is there a measurable benefit between the single and the multiple padded helmets?
I haven't seen any research on those, but you would think that what's been shown in bike helmets and in some ski studies is that people don't necessarily abide by the get hit once and then have to throw out the helmet. As long as it still fits and it doesn't have a huge crack in it, people tend to continue to wear their helmets.
I mean the ones with like the 2 styrofoam or just one.
I'm not familiar. I don't know if there's any measurable benefit in that.
Brad, nice talk. For the novice snowboarder,
Mm-hmm.
is there any evidence or suggestion that when they wear wrist guards, they have a higher rate of elbow or shoulder injuries?
In what I've described there, or what I've read, that has not been seen. And there was also, I think, a protective effect at shoulder injuries, strangely enough, with wrist guards. Yeah, John?
The stuff on the ACLs and the skiers, those mechanisms, the man and foot and the boot, were from Ettinger and Bob Johnson's work in I think almost the 80s and not the early 90s.
Mm-hmm.
I think the 80s. And one of the things that they did is they had a little study where they showed ski controllers videos of people falling and racers carrying their ACLs and falls, and came up with a description of the right way to fall and the wrong way to fall, which is what we were alluding to, I think. And one of the interesting things about that is that when they showed ski controllers those videos, that group of ski controllers had a significant reduction in their rate of ACL tears. So there was something about watching these videos where they actually could learn to fall correctly and to maintain form that a lot of have to do with having your hands forward, different things that kept you going forward.
Right.
And it's interesting because that was one of the earliest, that was the first study that looked at ACL prevention in any sport, and it was a long, long time ago. And they've tried to do it in other sports and haven't been able to do it. But I still think in skiing it's valid, that I think there is a method to try to reduce your ACL risk in skiing.
Mm-hmm.
And essentially it's trying to ski correctly in a sense. So it's essentially having good form, and you touched on a couple of the things with the falling backwards, but there's actually pretty good evidence behind that.
That's great. Yeah. Thanks. Kirk?
For prevention of the lateral process of the Thales fracture,
Mm-hmm.
you mentioned decreasing the external rotation.
Mm-hmm.
Was there any evidence or mention of bending injuries happening more frequently in the knees or hips?
No, nothing's been studied in terms of the binding angles and risk of injury. Something that'd be interesting to do. All right, great. Oh yeah.
You didn't talk about anything like strength training correlated to reduction of injury.
Mm-hmm. From what I came across, there is not much literature on strength training and reduction of injury. Yeah. Bruce?
Yeah. I think in ACL injury particularly, there's two groups of injuries. There's the novices who, the skiing and snowboarding, who predominantly injure themselves getting off, on and off the lift, where strength doesn't assist them. And then there's the expert skier and snowboarder whose own ability is their own demise. So they try and salvage themselves from a position where in the average skier they'd inevitably just fall over. And it's that being able to drive themselves out of a overflexed or a flat landing type of position. So in fact, strength and ability may be part of their problem rather than the cure.
What do you think about these half pipes? Because when I was in Harborview as a resident, and they used to say that the LD50 for a fall from a height, so like the lethal dose where half the people would die if they fell from this height, was somewhere like 33 feet. And it's interesting because if you have, as you pointed out, if you have a 25-foot height and you're able to get yourself another 10 feet into the air and you drift towards the center, you're falling a distance that, at least theoretically, you know, has a mortality of about 50%. So clearly that doesn't happen very often. You don't hear about it that often.
Mm-hmm.
Yeah, that data is a little serendipitous rather than scientific. In fact, there is this study of falling from buildings called autocalabesis, which was based on someone who took a peculiar interest in it in Scotland. And it depends how you fall, how many floors you can survive. So if you land on your head, that data is probably correct. If you land otherwise, it's probably grossly inaccurate.
I think a lot of it too is if you land onto a slope, which is mostly what happens in a half pipe, then that dissipates the force of your fall quite a bit because you're landing on a hill just like a ski jumper does. But if you actually get yourself all the way out to the center of the pipe, it's just curious to me. I don't know if anyone, if there's been, if you're researching this, if you came across any conversation about at a ski area, what is just a reasonable depth to create one of these things? And is this part of the conversation at all yet, or is it still just not even out there?
Yeah, it's not even out there at this point.
I would just comment that people who are falling out of buildings and windows are usually not wearing helmets either.
Yeah, if you fall from a floor with a helmet on,
Yeah.
it doesn't necessarily change the effect on your brain. So,
Was there informed consent for that study?
often these are people who chose their own demise rather than
Yeah.
How would you rate your call?
There's a university out of Wyoming that has been following the Dew Tour and making videoing all of the slopes that on half pipe and incident rates of they're categorizing like slide outs or crashes with head injuries, and they're actually doing blood tests before and after.
Oh, no kidding.
I think they're in their second year this year, so that should be coming out, I think, at the following next year. So
Oh, that'll be great to see. Yeah. Yeah, thanks.
All right, everybody, thank you for coming.